adverse effects on not just fertility, in other words, getting pregnant, but also on pregnancy outcomes.
Dr. Jacobs, I want to pop in here and just welcome those who are joining us in the live stream. We finally got it working. We apologize for the technical difficulties. I am Alice Creasy, co-founder and CEO of Ovum Health. We are a non-invasive network of virtual fertility practices. I am here with Dr. Jacobs, who's been an expert in PCOS for more than 4 decades, and Lauren Herring, who is our head of nursing and VP of Ops. We are thrilled to bring this topic to the masses. We see a lot of PCOS in the practice, but we see a lot of undiagnosed PCOS in the practice. So this topic is really for PCPs, OB-GYNs, and as much as it is for the patients. So welcome, and we will be doing this as a monthly series. We're thrilled to have you at the first one. Dr. Jacobs.
And Alice will also remind you that this is being taped so that you'll be able to see the entire presentation. So coming back to what I was saying about the adverse effects of obesity, whether or not someone has PCOS or not, but they're overwhelming and indisputable with numerous studies over the last 2 decades. So it not only will hamper one who's trying to get pregnant on their own in terms of a lack of proper ovulation or a lack of proper progesterone production, but even those that are on high-power fertility therapies, whether it be ovulation induction with insemination or IVF, either way, pregnancy rates are adversely affected by obesity, as well as the perinatal problems. And again, just to emphasize, this is a significant problem in the United States, and this is, as I said, closer to 80% in Hispanics. And most are aware that there's an ongoing childhood obesity epidemic in the United States and has been for many, many years. So what happens with the obesity component, and I find it interesting, by the way, that many general OBGYNs and family practitioners will always focus on the obesity part of it, and yet that's not even included in the 3 criteria that are part of the Rotterdam criteria for making the diagnosis. So yeah, it's true that about 80% of the time we do see obesity, but obesity, even without PCOS, is very, very harmful. And this is what I want to emphasize. So with obesity, again, with or without PCOS, you see changes in the hypothalamic hormones, pituitary and ovarian hormones, and abnormal insulin secretion, which we'll be talking about quite a bit. And these changes, just from obesity, lead to these other numerous signs and symptoms that are characteristic also of PCOS. Here's the more complicated portion, which I want to emphasize. If it's unclear, do not hesitate to email me. I'll be more than happy to share some slides or share some information. But what causes it, the insulin resistance? Well, we now know that there's a very definite genetic link that is present in many of the fat cells in women with PCOS, as well as those that have insulin resistance. And they've discovered 2 primary genes that are adversely affected, in that there's overexpression of this particular gene, and there's decreased expression of the GLUT4 gene. Now, what's this gene, and why do I want to spend a moment talking about it? This gene leads to the production of the GLUT4, the GLUT4 protein. And this is the protein that's a major player in transporting glucose into the cells of the body. So if this is decreased in its production and you have a decrease in that GLUT4 protein, there's going to be harmful consequences. Let me show you, without blowing you away, I want to simply demonstrate something, and that is when there's a certain level of glucose in the body, in the circulation. This is showing an individual cell as a schematic, and this is the 2 lines are a cell membrane. When the body recognizes an increase in glucose, it responds, the pancreas responds by producing insulin. Insulin then has to attach or bind to its insulin receptor, which is on the cell membrane. That stimulates a whole cascade of events here. I just lost my pointer. a whole cascade of events, the primary one being it allows this GLUT4 protein to go from inside the cell out to the cell membrane, where it then acts as the major player in transporting glucose into the cell. So it makes sense that if there are certain effects that are causing this gene not to produce this protein, it's going to have serious consequences, ultimately causing increases in insulin because the body has to work that much harder.
If you have this genetic component, Dr. Jacobs, does that mean you need medication to overcome your insulin resistance?
Not
Or
at all. Not
not?
at all.
Great.
And we'll talk in a moment about some of the genetic reasons for this and why it's important to emphasize that women can do more for themselves. I'm not saying it's easy to do, but they can do more for themselves just with lifestyle changes. And yes, many times we have to resort to medications, but they're independent of each other because one will clearly boost chance of success and also a healthy baby, which people often overlook. It's not just getting pregnant, it's have a healthy baby. Now, so the vast majority of women with PCOS or obesity have insulin resistance, where the cells, as I showed you, don't handle insulin properly. So what happens? In order for the body to maintain normal glucose levels, because the cells of their bodies are more resistant to insulin, they have to overcompensate and produce considerably more insulin. And this is what leads to hyperinsulinemia. This is the culprit or the result of insulin resistance. Now, don't get blown away by this slide, please. But as I just mentioned, when the GLUT4 does not respond sufficiently to insulin, you develop insulin resistance and overproduction of insulin in order to compensate. This is why I said earlier that the hyperinsulinemia is the major player here, because this culprit will lead to multiple changes in the hypothalamic, pituitary, and ovarian hormones. And this results in changes with ovarian androgen production, to have higher levels of androgens, higher levels of LH, and also changes in the liver so that the sex hormone binding globulin is lacking, and therefore there's too much free testosterone. All these things add up to PCOS. Now, as I've tried to emphasize earlier, misdiagnosis is not at all unusual. And there are many, many implications for fertility because this is primarily the number one reason leading to ovulatory dysfunction. In other words, PCOS is the number one diagnosis in that category. But it also leads to many, many general health problems. And this is, again, often overlooked. Here's the emphasis on this slide saying it's not just an infertility problem, because it isn't. And here's a laundry list of some serious problems that will develop inevitably if there's no treatment. And it's not just things like metabolic syndrome, diabetes type 2, cardiovascular disease, heart attack, stroke. Those are serious. And I don't think it's coincidental that you're seeing considerable increase in cardiac disease in the female population over the years. Is it related to obesity? Is it related to PCOS? I don't know.
I want to underscore what you said, if no treatment. And part of this talk is recognizing that diet and lifestyle modification is a treatment. And so there's traditional kind of medication treatment, but we are advocating for diet and lifestyle modification because this is a scary list. And I think that the take-home message we always want to emphasize at Ovum is that there are things that you can do to reduce your risk of developing these comorbidities, these additional conditions. And Lauren, you'll talk in a little bit, but do you want to give just a really brief preview of what it looks like in our wellness program to make sure that we're not just going to give people a laundry list of, hey, go do all these things and change all these things overnight.
Right. Well, we know that's not something that anybody can maintain, including all of us here on the panel. So our goal at Ovum is to really help take our patients step by step and make small, manageable changes through their diet and lifestyle so that they can have lasting effects. And as you said, avoid hopefully developing some of these complications later.
Thank you. Back to you, Dr. Jacobs.
Thank you. So obviously, all of these are very, very serious consequences, including cancer. And I don't say this to scare people. I say it to make them aware that nobody likes having periods if they don't have to, especially men. But the bottom line is you must have regular periods or be on certain medications to prevent cancerous changes from taking place. Because if a number of years go by and a woman's had one period a year, 2 periods a year, it becomes quite clear that initially the lining of the uterus, the endometrium, develops a condition called hyperplasia, a buildup of tissue that, again, if left untreated, will result in endometrial cancer. So this is a big deal. And in most cases, the only women who are getting this type of endometrial cancer are younger women. We're not talking about the typical 70, 80, 90-year-old woman who may develop uterine cancer. We're talking about young women. And then lastly, just to throw one more shout out about depression and psychosocial problems, because I saw this quite often in my general practice, where it makes sense that if you've got a gal that's 14, 16, 18, and I can say gal because I'm 75 years of age, but if you have a young gal that has body image problems with obesity, hair loss, excessive hair growth, acne, you're not going to see very good self-esteem. And very often there are problems with depression and anxiety. So please be aware of that. It's a very serious consequence that oftentimes will lead to other eating disorders. So what about the screening? Well, this is an important first step. I mean, the awareness is the important first step for clinicians as well as patients. As I told you before, there's no single test to be able to make the diagnosis. And that's why it's important to have a comprehensive evaluation to rule out other conditions. Here again, who should be evaluated? Well, you can see from this list, any of these symptoms that are present or identifiable should be investigated. And many variable presentations, as I pointed out before, where you may have obesity in most cases, but you may have lean PCOS. You're not going to have everyone with menstrual irregularities or hirsutism. By and large, you need to evaluate many, many women for this condition. Now, quickly to go through this. With a screening appointment, it's fasting so that you can get other chemicals measured other than just the hormones. And it's done on cycle day 2, 3, or 4 of a woman's menstrual cycle. A careful history is important to find out about episodes of skin changes, hirsutism, menstrual cycle irregularities, etc. And then physical exam to look primarily for skin changes or blood pressure changes that can be done typically by their primary care physician. As we talked earlier, a very important ultrasound to count the number of follicles and see if there is the appearance of polycystic looking ovaries. A series of blood tests where most of these are endocrine related, but you want to evaluate thyroid. Down here, you see adrenal hormones. There's several tests that are done to exclude adrenal hyperplasia, adrenal cancers as well. So this can all be accomplished in one appointment, and yet it's rarely done. Now, again, just to hammer this home one more time, we're talking about combinations of genetics and lifestyle. And we'll focus more on talking in a moment about epigenetics. That's really what's going on here. It's not a genetic mutation, for example, or a break in a chromosome. It's changes in how the genes are able to function. But all of these changes that you can see from this complicated slide end up leading to changes in the androgens, increased insulin, polycystic looking ovaries, and ultimately other serious cardiac and liver problems, as well as type 2 diabetes, which is almost inevitable in women that are not being treated at a younger age for PCOS. Apologize for a dry mouth. Now, let's talk about epigenetics, because this is really going to impress your friends. And it's relatively a new science that is getting much more attention now because we're getting a much better understanding of how we're destroying ourselves health-wise. Now, it's the study of changes in gene expression. In other words, how a gene can function due to environmental and lifestyle factors that do not alter the genetic sequence. And that's what I mean before. It's not a genetic mutation. You're not missing portions of the gene or replacing portions. It's how it's affecting the gene's function. And again, this is a term that I don't want you to think about tonight, called DNA methylation. I can't even say it with dry mouth. And this is what happens, is that you get attachments to various portions of the gene that makes it difficult or impossible for the gene to function the way it's supposed to. And that's what we talk about in terms of affecting gene expression, not a mutation.
This is the point where I get excited about the lifestyle modification, because it's very grounded in science, that it's not a life sentence just because you have a genetic predisposition to that very complicated side of symptoms and side effects and long-term risk for comorbidities. We all have risk of something. We all have some genetic predisposition to not perfect health. That's just the human condition. And this is where I get excited, Dr. Jacobs, about knowing I can make a difference on my own body, that I can make a difference on those health outcomes. It really does matter. You know, it's not just about exercising because I want to look thin or reduce body fat or look good. It really is about impacting what's going on the inside. And I think that that's very motivating.
I think maybe 25 years ago, the most exciting development I saw with IVF had to do with genetics, in terms of being able to test embryos for various genetic mutations and diseases. I would say in the last 5 years, epigenetics has exploded and is now taking over, helping us understand how things happen and why they happen. And when you talk about lifestyles, whether it's improper diet, exercise is lacking, smokers, less sleep, too much alcohol, recreational drugs, these are affecting our genes' function and gene expression. And if that doesn't scare you enough, understand that these changes that occur, these epigenetic changes, are generational. And there's plenty of evidence to show that. Meaning, if you're doing all these lovely things in terms of your poor lifestyle, that's going to be reflected in your children. And that's a very scary thought. And your children's children, from everything that we can tell so far. So this is a relatively new science, but it's wonderful because it helps explain how we can take care of ourselves. And I highly recommend, take a moment to write it down. What is epigenetics.com? This is a superb website that has a section for scientists and clinicians, has another section for the general population. It's a remarkably educational, and it tackles everything. It tackles all of these issues of smoking and alcohol and depression, anxiety, all these negatives, and how it has such an impact an impactful moment throughout our lives and our children's lives. That's the part that's scary. This, by the way, is on their website, and I think it's under $5. It's an ebook, and it really talks about how diet may influence our epigenetics and our health. It's superb. I've read it. It's worth looking at, and it's $5.
I think it's worth bringing up too that it's not a one size fits all, right? That is the uniqueness, and I think we've all been a culprit of hopping onto a Facebook group and saying, well, what did you do for this? And I did it because I had 4 IVF failures, and I was going to all the groups trying to find the autoimmune protocols and like, well, what exactly, did they prescribe and what's the dosage? And I felt victim to it too, just looking for that one size fits all answer. So the good news is there is no one size fits answer. The bad news is some of this is a little bit on the experimentation side. There's some best practices that are universal, like sleep quality, that Lauren's team does a really great job at Ovum tackling with our patients. But I would say that it's also very additive and not restrictive. So when people see things like alcohol on there and they're like, oh, are they going to tell me that I can never have a glass of wine again? And the answer is no. So I think that keeping that in mind, this is very approachable because it is more additive. It's not so much restrictive. And in fact, most of the patients that come to us, Lauren, would you agree, have already been restricting themselves so much that they end up showing up to our practice anemic with vitamin D deficiency, vitamin B12 deficiency, because they're restricting their food so much.
Absolutely. That's one of the highest things we see is people who come to us who've already struggled through years of eating disorders because they're trying to figure this all out on their own. And it's something that absolutely we can help with these small changes rather than large overhauls so that, we can make lasting effects.
Let me move on. So when it comes to treatments, the bottom line again, you got to correct the insulin resistance. And that's true whether you're trying for pregnancy or not, or even thinking about pregnancy in the future. Because when an obese patient or one with PCOS corrects their insulin resistance, many cases, better or normal ovarian function will return. And that's why you will sometimes see spontaneous pregnancies. People are often, amazed at somebody who loses weight, stops smoking, gets more sleep, suddenly is able to finally get pregnant. Well, it's not a miracle. Well, it's a miracle because they're all miracles, but it's not a coincidence. Okay? When people talk about, I went on vacation, I did this, I started to relax, who knows if it made a difference or not, but it didn't hurt. So again, we're responsible for taking care of ourselves, plus or minus, but you're going to hear at the end of this discussion why it's all under our control. And even in those patients that are doing inseminations, medications, IVF, pregnancy rates are higher in those patients as well when you correct for the insulin resistance. So lifestyle makes a big, big difference. And there are numerous studies that tell us that a weight loss of even 5 to 10% will improve pregnancy rates with any method of therapy, including spontaneous pregnancies. And of course, regular exercise, improving your fitness in general is also key. The insulin sensitizing products, such as metformin and semaglutide and some of the other, and there's a gazillion that are available now. But my point that I want to make, since I'm not going to spend a lot of time talking about the medical treatments, but look, all 3 are independent in their actions. So simply put, if you're exercising, taking care of yourself, and you need to rely on medication, that's okay because it's another way of having an impact on your insulin resistance. It doesn't mean if you're taking drugs that you can overeat or be healthy or not get sleep. It all adds up, but they're independent of each other. So in terms of both obesity and PCOS, the single most important factor for any clinician to tell their patients is lifestyle changes. That's a first step. And many decades ago, when I started as a reproductive endocrinologist, lifestyle changes was not even on the radar. Never mentioned, never discussed. So educate the patients, encourage proper diet, weight loss, regular exercise. But here's the problem. Simply telling a patient that they need to lose weight and start exercising does not work. Period. The solution, however, is to seek professional guidance, have a team approach with people you're working with, patient education. And frankly, that is Ovum's way. That's Ovum's mission, with many different types of clinicians, nutritionists, coaching. That gives you a much better chance of being successful. But it's not an overnight success, and it takes time. I want to just close by talking about a couple of the diets and recommendations over the years. And the first one that came out many years ago was out of Harvard, and it was called the Fertility Diet because they had looked at thousands of people in terms of retrospectively how do they eat and what are some of the consequences. But this was not well regarded in all circles, but it was a good start. So they focused on the monounsaturated fats, not having to avoid all fats. The vegetable protein instead of animal protein, carbs that have a low glycemic index, the good carbs, if you will. High-fat dairy, that blew people away because it didn't make sense to people that were talking for years and years and years about the low-carb diets, etc. But fiber and exercise also played a major role. But that was a good start many years ago when this came out, and people started to recognize that the two were connected. Some of the more recent PCOS diets that have been helpful and popular, this one, the PCOS Diet Cookbook. This one, also from Harvard, is their Healthy Eating Plate. You can Google that, and you'll find that very interesting and useful. And the keto diets, although many people frown on them because they're difficult to maintain, but they're effective in terms of the type of weight loss that you're looking for in a PCOS patient especially. Myo-inositol, when it talks about adding certain supplements over and above dietary changes, there's a considerable amount of evidence now for many, many years that myo-inositol, which is in the B-complex family, helps to increase a patient's insulin sensitivity and definitely improves ovulation function. As well as with IVF patients, not only higher numbers of oocytes or eggs, but also better quality. So this has been a very popular supplement to fertility patients in general, in addition to those that are either obese or PCOS. The only thing I want to say about metformin, because the use of these types of insulin sensitizing medications is very helpful in controlling insulin resistance. However, it can be very tough to take. There are many, many people that have tried it, gone off it, were forced to go back on it, couldn't stand it. So even though it's an effective way of controlling insulin resistance, not very popular. And I also want to emphasize that the reason I put this up is because some studies, not all, but some have shown comparable benefit from just taking myo-inositol and proper diet, comparing that to those patients on metformin. But that's all I'm going to say about metformin or other medical treatments. Important to emphasize that it's not just about getting pregnant. And I said that earlier, I'll say it again. Too many people focus on, I got to get pregnant, I got to get pregnant. Don't want to take the time to spend 6 months getting healthier or take the time to start exercising. God forbid they waste 6 months of trying. Well, you know what? There are a lot of patients come in, they're 35, 40, 45. You can still improve your health and have a better outcome, even though it may take some time. But we're all impatient, and that's what gets people in trouble, where they get pregnant either on their own or with other fertility therapy, but they were in very poor health to begin with. They're not going to get better when they're pregnant. So it shouldn't be a surprise that unhealthy patient can often lead to an unhealthy baby. All of these changes are related to what you see with obesity, and there are many, many studies to back this up. So what are the take-home messages? In terms of, we focused on education, motivation, counseling, a team effort. Women certainly need to be informed that obesity has serious consequences to getting pregnant and also many dangers with the pregnancy once they've achieved a success. The big picture is what's important, not I got to get pregnant. Obesity may be a chronic condition, but it's treatable. You got to make the correct diagnosis. So always be thinking PCOS awareness. Simply telling a patient to lose weight is not going to work the overwhelming majority of the time. So that this can be solved and improved, but it takes time, motivation, counseling, behavior modification, lifestyle changes have to be first and foremost. Otherwise, it's very difficult to maintain a weight loss. So thank you very much for listening, and I'm happy to answer any questions that you guys may have.
That was fantastic, Dr. Jacobs. Thank you so much. I definitely want to go deeper on epigenetics, I think, in another monthly webinar. I think it is such a fascinating topic, and absolutely, you're right, really burgeoning. Lauren, could you walk everyone through kind of how we approach it in really accessible segments where we don't just throw a list at patients and then expect them to walk away kind of implementing all this change? What does the preconception part of everyone's treatment look like?
Yeah, well, and I think, that's the unfortunate part is we hear so many patients who come to us and say, well, I was just told I need to go lose weight and given no resources. And, so we see this huge need out there, but every person has to be individualized. So we take at the very first, initial appointment with one of our fertility providers, we're going to take a very detailed history, go through your entire records, hopefully bringing everything to that first appointment, and then determine which specific tests are appropriate in your case. And then once those tests are done, then we have you circle back, and those tests are going to be looking at things that are beyond just the overview, scratching the surface. We're looking even more so at, again, some of those nutritional deficiencies. We've talked amongst our team, over 90% of our patients are deficient in vitamin D. So all of these things are something that we're going to look at in this initial phase of testing, so that then when you meet back, you can actually create a manageable plan with your fertility provider, where we get our patients then to our amazing nutrition team, so we can implement touch points throughout a 12-week program where we're going to focus on one area at a time and not do massive overhauls. But for example, when we talk about sleep, everybody, you probably talk to at least, once a day, somebody could say, oh, I struggled with sleep last night. It was an awful night. And so, just finding small ways to improve the quality is one area we can work on. We'll talk another week about getting the right kind of exercise, not over exercising or under exercising. It's all about balance. And so what Ovum is here to do is to help each of our patients really come up with their own plan that we can walk you through step by step.
And then we're supporting you with educational materials, inspiration, and frequent kind of check-ins so that you don't feel like you're on your own. I think that is also just really important. So we move you from the diagnostic phase to the preconception treatment, and then you get to graduate to the fertility treatment stage. Because truly, even if someone is ovulating on their own, which is the outcome that we do want, we also then like to make sure that we're teeing you up for the best possible chance of success without spiking hormone levels. And we're going to do that. And correct me if I'm wrong, Dr. Jacobs, but it's good for us to sort of control the growth of the egg, control the timing of the release of the egg, so that when we are instructive even about when you're having intercourse, it's really to have the best possible chance of success, knowing that you already invested these months cleaning up your health and optimizing everything that you can so that natural fertility is possible.
And I think it's important to emphasize too that um, I'm a big fan of various medical treatments, whether it's inseminations, medications, IVF, and I've helped with God's help thousands of couples over 4 decades. So I'm a big fan of these treatments. But my point is that taking the time, if you have the luxury, and I'll get to that in a second, taking the time to make these changes will invariably have long-lasting effects on your chances of getting pregnant and on the health of the baby. And I think not everyone has that luxury. In other words, the 43-year-old that comes in desperate because now she realized she would like to have a family, the bottom line is she doesn't have 6 months to a year necessarily to get as healthy as possible. So I'm not saying, this lifestyle issue affects or benefits everyone. Of course it benefits everyone, but not everyone may have the luxury of time because everyone's aware that women are waiting much too long to attempt pregnancy. But you don't always have the luxury. Now, in a perfect world, if you have time, you get healthier, you make a better baby.
Great. Does anybody have any questions for us? Please use the Q&A or the chat and we can route them to Dr. Jacobs. And if you'd like to get in touch with us or Dr. Jacobs specifically, please email hello@ovumhealth.com. We will route it to the right place. We also have a fabulous provider who's an OB-GYN by training and has the lifestyle medicine certification. We're leveraging, you access Ovum and you get a multidisciplinary team, which is really incredible. So you don't just get the wisdom of 4 decades of experience from Dr. Jacobs, you also get the benefit of all of his colleagues, whether you're seeing them or not. So I just want to, if there's no questions, and I want to wrap this up and thank Dr. Jacobs and Lauren for all the hard work it went into preparing this topic. And to those of you who registered and were able to join us today, we at Ovum love what we do. We are on a mission to help you get pregnant, stay pregnant, and live to watch your babies grow. So thanks, everybody, and we'll see you next month.